And it's my pleasure today to introduce Ann McLeod. Ann is the Senior Vice President of Policy and Innovation at the California Hospital Association. Her career spans 34 years, including 12 as a financial executive at several hospitals and health systems. She joined CHA in 2007. Thank you so much, Ann.
Thank you. And the hardest part of today was when Demetria said, Ann, come up with your panel. So wrangling the panel. So we made it through that, so that's good. My job is going to be so easy today. When you moderate a panel, you know, your job is to make them look good. I should just exit stage left. Really pleased to provide this panel to you today. Demetrius and I have been talking over the last couple of months ago. We started talking, you know, hey, Ann, could we put something together maybe around CHA's work on affordability, some of the things that are going on in that direction. And I said, I don't know, that's kind of boring. What can we do that is really meaty and meaningful and is really going to drive change in healthcare? I said, you know, kind of at the root of the affordability is our position that we've taken on really integrating care, coordinating care, working together on behalf of the patient for the patient's health. So we talked a little more about it, and I said, hey, you know, we did some work with USC, and Dr. John Romley just, you know, did some work and wrote a paper for us. I bet I could talk him into, you know, coming and meeting with us and having a conversation. And then I thought, so, you know, the other one that would be really good to get, who's really a transformational leader in Southern California, is Barry Arbuckle and the work that they've done at Memorial Care. They have like over 200 sites of location for patients to get access to care. Let's see if we can make that happen. And he said yes. John said yes. Barry said yes. And I said, you know, but I really also love the output, the work that IHA does with their atlas, and they measure value. They look at the integrated care, the impact on quality, the impact on costs. Let's ask him. And they all said yes. So it was just like the perfect storm. So really happy to bring this group together today. We changed up the order just a little bit. So each speaker is going to talk to you for 20 minutes or so. They have a lot of good information to share. And then after that, we'll have plenty of time for some questions. And I really want it to be, you know, bring all your questions, challenge them, ask them how they do it, because they do some great work. And but we're changing it up a little bit from what's on the screen. I'm actually going to have Jeff Rideout go first. And so let me introduce on my right. We'll start with Dr. Jeff Rideout. He's the third of our overachiever on the panel. They're all overachievers. This is wonderful, and they all are doctors. He's a Harvard Medical School grad. His undergraduate was at Stanford, and he received a master's degree in economics as a Rhodes Scholar at Oxford University. So I'm just not feeling really fancy here.
Thank you, Jeff.
I've had the pleasure of working with Jeff on some efforts to promote value-based care in his current role as president and CEO of the Integrated Healthcare Association. His organization maintains massive amounts of data on cost and quality for, I think, over 29 million Californians. So the work that they do is meaningful and important and points us in the right direction. I'll introduce the other two speakers when we get to them. Right now, what I'll do is, I think we need a clicker for, here's the clicker. We need a clicker for Jeff. And we'll let him walk you through IHA.
Good afternoon. How's everybody doing? I don't know whose resume that is. I grew up in Oregon, drove a Camaro, had a big afro. It was destroyed all those pictures a long time ago. Thank you very much for having us here. You probably don't know much or anything about IHA. We're not IHI. We're not AHA. All those letters were gone by the time we started. So this is an organization that's truly unique. And I served on the board of IHA for about 15 years off and on for 3 or 4 different organizations. And I will tell you, I never really understood either what the organization was or how they got anything done. But it's a little bit of magic, and it's a little bit of secret sauce. And I think the best thing I can do is kind of keep it going on behalf of the citizens of California, because it does require, and I believe it's Dan Gross was honored, I've never met you, Dan, but what you said about the community here in San Diego really felt very good and very familiar in the sense that most of what I think IHA as an organization has been able to accomplish has been about relationships. It's been about cooperation. And, we have lots of little taglines that kind of keep the engine going. But I think the one that comes through the most sort of in a practical sense is collaborate to compete, because you'll see as I go through this, the people that are part of IHA, including Memorial Care, they really have no reason to coordinate with each other. We have all the largest health plans. We have all the largest risk-bearing provider groups. We have many of the largest health systems. We have the state's chief regulator as a non-voting member on the board. We have pharma. We have employers. So imagine putting all those people in a room every quarter and having something actually meaningful to say and not having it turn into a food fight. So it's actually been a really interesting experience on how to advance common problems or common agendas if you can find them. So on a good day, what I say about IHA is we will forever have work to do because there's just so many things to do to make the system work on behalf of patients and enrollees better. On a bad day, it's kind of like a lunch club. People get together and we have a speaker and then they go back to kind of their turf wars afterwards. And fortunately, IHA's had a good run over the last 25 years, and it is our 25th anniversary this year, so I'm using our freshly minted marketing slides because if I don't use them here, I don't have anywhere else to use them. But we've tried to kind of up our game a little bit, not so much in just sort of how we represent ourselves, but actually helping people understand what we do. So more recently, we've made some runs at legislative, not influence and not even lobbying, although we can, but just awareness, because I think a lot of the information that we are collecting on behalf of our members has some pretty important policy and other uses. So I will give you a little bit of background. I think fundamentally, and for those of you that have health services research training, some of this will resonate. I don't formally have that training, so if I get out over my skis, I think John's going to pull me back in just a little bit. But most of this data is observational. It's information we collect and procure from our members voluntarily, and then we try to standardize it and collect it in a standard way, but also normalize it, and then present it using common definitions and common benchmarks. So really, if there's anything unique about what we do, it's the attempt to essentially do true apples to apples on things that, at least a subset of things that can drive the industry in one direction or another. So our historic core program is called AMP, and it's really measurement at the physician organization level. And for those of you that maybe remember some names like Steve McDermott and things like this was really the attempt in the heyday of managed care to demonstrate the value of the integrated model, and to do so with conviction, and to do so in a way that would allow that model to thrive in an environment that wasn't necessarily supportive of that model. So where we've grown from there is we cover about 12.2 million Californians through 4 different programs, and I think Greg Butchert may still be here, but they're the newest addition to the different programs we have around Promise Healthcare. So we're covering 9 million lives in commercial HMO at the provider organization measurement level, almost 1 million now in commercial ACO, so that's our newest program, again, where we're doing standardized measurement across many of the different commercial ACO models that are emerging. Almost 2 million, or almost half of the Medicare Advantage lives, and then we are doing a standardized value-based P4P program for Medi-Cal, and there's some interest, obviously, with what's going on at the state level. Could we apply some of the work we've done in standardization that we've done in a broader way? We also, as Ann mentioned, about 4 or 5 years ago, were asked to support what's called the Atlas, and I don't know if there's any marketing communications folks in the room, but when we launched the Atlas this year, we got 90 million impressions. I don't even know what an impression is exactly, but it seems like there's a lot of something going on there. And people have really resonated to the notion of having a place where at least some standard metrics and comparisons can happen. I think it's important to note that we get member-level data for all of this with the exception of Medi-Cal. So my little pet peeve in all of this is that while Medi-Cal provides us a lot of information to use in our presentations, they calculate the rates themselves. Everything else is standardized. The data submission formats are the same. The measurement rules are the same, and we actually calculate the rates using a third-party vendor. So we've got a lot of stuff, and again, it's a very delicate but important balance between why do people give us this information and why do they want to give us even more information. And there's been quite a bit of growth even in the last year. We've got 3 new health plans submitting information. We've got 34 new provider groups participating in the program. We've got 5 purchasers. I'll go through some of the participants. And I think it's because at the end of the day, most of us want to get to some measures that feel like they're honest and reliable. Now, whether we use them or not, I think my pet peeve is I have no idea really whether people use this to make contracting decisions, to make network configuration decisions, but at least it gives people a sense that maybe at the worst that they're confirming kind of what the impressions are that they had just working in the industry for as long as many of us have. These are the groups that participate, over 200 risk-bearing medical groups and IPAs, ACOs, FQs, 5 purchasers. They don't participate in all of our programs, I want to be clear, but they do participate in many of the programs, and it represents our community, if you will. A lot of purchasers. We made a conscious effort to include purchasers in our community, and for people that aren't familiar with IHA, that's kind of like those strange things. Well, how can you have purchasers and providers and health plans all at the same table, and the people they're being regulated and the regulators in the room at the same time. So it creates a fairly interesting and unique dynamic. We also do a lot of work with national organizations, including NCQA and other folks like the Pacific Business Group on Health. So why do we do it? Well, this is a comparison of, I think we had to truncate this, but we have information on over 200 provider groups in California, and if you looked at all of the health plans that measure one measure, in this case colorectal cancer, but it's true for all the things we do, this is the range of performance for any one of those groups based on the high and the low of their plan partners, if you use the plan measurement. So I don't know what to make of that. If you're a medical group like Memorial Care Medical Group, is that truth? Is that false? What's the reality? When you aggregate this across the industry, this is what it looks like. So basically, from a statistical point of view, we're reducing the variation by aggregating the results and standardizing the results and standardizing the measurement. So each of those, you can't really see them, but that orange line represents a different medical group in the state. So I said we do a lot of measurement. So there's measurement, common measures, common results, benchmarks. And think about it, if you're going to translate something that's fairly routine like a HEDIS measures are designed for plans. We have to go through a whole translational exercise with NCQA to say what makes that measure appropriate for a provider organization. And if you don't do that, the measures don't really work very well. So there's a lot of work that gets done just to say, how can we make this comparable, even if it looks the same? I'm sure most of you that work in this field know there's 4 or 5 different measures of immunizations, combo 9, combo 2, combo 5. And even within that, the definitions are different. So there's a lot of things that you need to do to get to an apple, and it needs to be, all Granny Smith or all Fuji, because even those slight variations make a big difference. We do a value-based incentive design. Legally, we can't pay incentive, but we have standardized design features that gets modified and improved every year. When I started as CEO 5 years ago, there was no payment for maintenance. So a group that put a lot of work into getting to a high level of performance on a quality measure or patient experience or total cost of care, there was not an incentive reward built in for them to stay there. There was always an incentive reward built for improvements. So we've changed something like that. We could apply this in other settings if people want. It's more like think of it as a bit of an open source library for design features. We do public recognitions of high-performing groups, mentioning Barry since he's on the panel, and he's been on my board, and he's on my executive committee. Several of their groups were recognized for what we call our Excellence in Healthcare Awards. It's about 30 groups a year, or a little more, or a little less, that perform in the top half of patient experience, patient quality of care, and total cost of care. And that sounds like a low bar, but to get into the top half of all 3 of those categories and to do that consistently is actually really tough. So we go from about 200 down to about 30. And then there's also a public report card. So unlike a lot of places in the country, medical groups and IPAs in particular are willing to be reported on total cost of care and be rated on that. I sit on a national committee for AHIP and CMS for ACO measurement, and even though that is supposed to be the front end of alternate payment models, there is no appetite whatsoever for putting total cost of care into the picture of standard measures. There's a lot of sort of technical reasons. It requires licensing of a vendor solution for risk adjustment, things like that. But at the end of the day, if we're going to talk about affordability or value, you can't really do it unless you standardize the measures that matter in terms of what things cost. This is just a depiction of sort of where we've gone over the last 15 or 16 years in terms of trying to keep up with the market. So one of the things that's been really hard for us is we had a great program that the market shifted away from. So as all of you, I'm sure, are aware, about 60% of the HMO market is Kaiser now. And Kaiser is in our program. They compete. They send us their data. It's standardized in the same way as everybody else. But a lot of the market shifted to either PPO plans or variants of that, ACOs. And what we've tried to do, especially since I've gotten there, is say, how do we kind of keep refreshing the performance measurement so it keeps up or at least isn't too far behind of where the market is going? Because measuring something that was great 10 years ago or maybe wasn't great but isn't important now, that's a hard thing to do if you're not kind of reinventing yourself as you go. And that's forced us to be a little bit more nimble and a little bit more market-oriented than we had been in the past. So a few results, and then I'll stop talking, but just that was more to give you orientation. Oh, also a quiz. IHA is a 501c6. Does anybody know what a 6 is? Barry, you should know that.
I'm not going to say because it would be
Oh,
unfair.
that's right. So there are 39 ways to be not-for-profit in the IRS tax code. So most of us know 3s and 4s, which are charitable organizations. A 6 is called a business league, and its sole purpose is to do something on behalf of all of its members. So it really comes back to who the member is, and I think CHA is a 6. Another 6 is the NFL, if you want to put it in those terms. So what I've come back to over and over again, I didn't know that before I came to IHA, but what I've come back to over and over again, the only reason we exist is just find something that every one of our members feels is important to their business. And when you have hospital systems, when you have risk-bearing providers, purchasers, pharma, employers, regulators, it's pretty doggone hard to find something that everybody wants to do. But that's really been kind of what we've tried to focus on, is how do we help you do your business better? So some of these results maybe you've either seen or aren't surprising, but I thought I'd show them to you. One of the things that we've seen over the last couple of cycles of the Atlas is when you look at risk sharing, financial risk sharing, what's its relationship to clinical quality and total cost of care? And this is very simply drawn, but it's accurate. When you look at 10 standardized measures of quality, preventive health and chronic care inclusive, and you use a standard definition of total cost of care, what you see is the more risk, the better the value. Higher the quality, lower the cost. And we also use a standard definition of cost that includes patient cost sharing. So this is not about sort of what premiums are doing, it's what is the total cost of care. And if you think about it very long, what that requires is that we're measuring things at the individual enrollee level. So this is all coming back to the calculations of how's this impacting enrollees. So theoretically, if the medical group is the unit of analysis, we can tell you whether the range of capitation or financial risk sharing for that medical group across all of its payers based on the actual enrollees that go there. So some of this has been used. There's a JAMA opinion piece that came out, I think, yesterday from Alan Enthoven and Steve Shortell and Victor Fuchs, where they're using this data. The Petra Center at Berkeley has been using this data as part of their statement. I think one of the things, and maybe John will talk about this a little bit, is what does this mean with regard to clinical integration? What does financial risk sharing mean in regard to clinical integration? And probably more importantly, as a market dynamic, what does it mean in terms of consolidation? Are the benefits of clinical integration worth it? Are they running in parallel or against the grain with consolidation? How do those things relate to one another? And really what we're trying to do as an organization is say, let's at least get the data out there so we can have that next order conversation, because it's all about HMO versus PPO or North versus South or risk versus no risk. It really doesn't help us kind of look at what's really driving these kinds of performance differences. This is another way to look at it. All those little dots are individual medical groups. So if you look at hemoglobin A1C control less than 8, and we see this, I want to be clear, we're not cherry picking our results. We see this in every result we measure. Those are all the individual performance rates for all the medical groups and IPAs in California. And I think the more interesting presentation that we're doing here is 93% of them are higher than the non-integrated care average for the state. So put another way, a random choice in an integrated system, regardless of what the planned benefit design is above it, but a random choice in an integrated system is better than if you went to the highest performing region in a non-integrated system geographically. So there's a lot in this that basically says there's something about integrated care that seems to be worth digging into. It may be overwhelmed by other issues, market issues, how people contract, how people network, how people consolidation. But we've tried to say, what do we think makes sense for IHA? And not surprisingly, the I is integrated. So it seemed perfectly reasonable for us to focus a lot on, what are we seeing in terms of integrated care. Persistence matters. All of you understand that, but this is looking at all the clinical measures in our provider group program and how they've gone over 5 years. Again, every measure, with the exception of the one on the right there, in a set of over 20 have improved, but they improve incrementally and slowly. The one that hasn't improved or hasn't improved a lot are ones that are topping out in the integrated model or have been removed because they're not stable or they're not felt to be meaningful. But we put them all up there to say, if you stay at it long enough in a system that has an infrastructure to support clinical care and clinical quality, things do improve. But you have to be willing to look at a longer-term view. And in some cases, it might be 5 years, it might be 10 years. We also try to translate what we do to what does it mean. So those improvements over the last 5 years actually have pretty important impacts to individuals, and those are just some of the things that we can back into from our data. Another interesting thing, which isn't surprising, but it's nice to demonstrate, when you look at how integrated care performs across different product lines, the groups that perform well tend to perform well across all product lines, and the groups that don't perform well do not. Now remember, not performing well is still better than a non-integrated system by far, but there's a distribution across integrated systems. And if you think about how people are organized to deliver care when they're integrated, they're not making distinctions between Medicare Advantage and commercial or Medi-Cal. They're organized to deliver patient care, by and large. I'm sure there's always exceptions. And what we see is the ones that are organized well perform well. And we see that in commercial ACO, we see that across Medi-Cal, we see that in Medicare Advantage. The other thing, new models can be assessed. I mentioned our commercial ACO program. We looked at, and this is by contract, so each dot represents an individual contract between a plan and an ACO. So it's not a group. This is how, for example, Aetna does with Palo Alto in their contract, although I'm not going to tell you which dot it is. So what this tells you is when you look at an index of clinical quality, again, multiple measures, against a total cost of care, there are groups in the upper right, green, that do well. The interesting thing about those groups is there's nothing about it from looking from the outside in that would tell you who they are. Some are in PPO models, some are in HMO models, some have prospective attribution, some have retrospective attribution. The bottom line is value can be achieved in multiple ways, and here's kind of a representation of that. So the marketing of an ACO in and of itself doesn't tell you anything. ACOs in general perform pretty well relative to non-integrated care, but what's driving that really is under the hood. And one of the things I say is we have to keep measuring this stuff because each dot is a relationship, and if people are willing to expose or reveal who that relationship is, we can all make better decisions about care. And it isn't going to be something as simple as what the marquee banner says or what the name of the organization is. So I'm going to stop there. Gives you an idea of the kind of information we produce. it could be incredibly valuable, or it could be completely ignored if it's felt to be either threatening or not how people are doing their contracting.
I know we said questions at the end, but I really want to ask you a question based on something you were saying, the importance of being able to measure true apples to apples and that standardization. And I've had something bothering me for a while, and I even asked John this during a break. How does or will the influx of healthcare spending for social purposes impact the ability to compare that total cost of care, not only among provider groups, but more importantly, comparing California to other states? Will California be an apple and the other states will be a banana?
Well, I think the short answer is yes. Our work is largely California-based, although we have many national plans that actually want to use some of the measurement outside of California. I think if there are groups, say, within California or systems within California that are spending more on social determinants of health, we want to use that phrase, it will show up as a higher total cost of care, but presumably with the risk adjustment and with the outperformance and quality that they're hoping to get, it should be reflected. Mechanically, it can be eliminated. If we can identify it, we can eliminate it, just like mechanically, if we want to include it, like capitation payments, which we do, we can include it. So I think it really comes down to, as I always say, it's not a technical issue as much as a decision between business partners. What are the use cases? What are the definitions? What are we trying to measure and for what purpose? So I think it's doable, but it depends on what we're trying to use the information for on the other side.
Helpful. I think it's something that we're going to have to think about going forward because we see more and more investment at the health level, at spending at the health level for those cost factors. And it just concerns me as a policy person how that's going to stack up. And we're going to continue to be criticized for high health spending when we're really providing a crutch for what should be social spending from other sectors.
Yeah, just one more final thought on that. There's an infinite number, and John will understand this much better than I do. There's an infinite number of factors that you can account for and either disregard or risk adjust out. So wage adjustment north-south, we include that. Risk adjustment, well, is clinical risk adjustment appropriate for all measures? Probably not. I mean, you don't risk adjust for preventive health screening. I don't know why you would. Language or income is a big one. Are we going to risk adjust for low income? And when I have talked to health plans, when I used to work at health plans, the decision to go to a market, knowing what the demographics are of the market, is a business decision. But that, in my mind, you don't risk adjust out those challenges. That just makes the challenge that much harder and more important for you to address versus your competitors. But not everybody thinks that,
Yeah,
So.
great, thank you. Let me next introduce Dr. John Romley, again, another of the three overachievers on the panel. He's an associate professor at USC's Price School of Public Policy, an economist at the Schaefer Center for Health Policy and Economics, and he's an adjunct economist for the Rand Corporation. Do you have any free time, John?
Not too much.
So we've had the great pleasure of working with John over the last couple of years. As I said, he's prepared several research papers for CHA. The last one had to do with hospitals and costs and an integrated environment versus those that aren't in an integrated environment. And he's going to share some of those findings as well as other information today. John?
Thank you, Ann. So I'm very pleased to be here. And as Ann noted, I'm a health economist at USC, and in particular at the School of Public Policy. For the UCLA fans in the audience, I hear the new saying is you can't spell USC without scandal. Or scandal without USC. That was backwards, excuse me. And we're not going to broadcast that. So I mentioned that I'm at the School of Public Policy for a reason. So has anyone in this audience ever shopped at the Price Club? Yeah, okay, so a few of you have. So our school is formally named for the Saul Price School of Public Policy because we received a generous gift from the Price family. The Price family founded the Price Club down here in San Diego. One of the things that's notable about their gift is that it also established a Center for Social Innovation, one of whose focuses, or foci, I guess, is homelessness, and USC helps up in LA County with the homeless count there. So I think that's interesting given what we've talked about today. From my own sort of weird personal perspective, it's a little funny to be at the Price School because I grew up in Arizona shopping at Price Club, going with my folks growing up. But I don't think that's why I was brought here today. I was brought here for other reasons. And I want to thank the Hospital Association for bringing me here. I was telling Ann that I was very excited to be invited because I think there's a lot as a researcher that I can learn from, if I want to do good research, that I can learn from people out there in the real world. And I hope I'll have something worthwhile to share with you from a researcher's perspective. I work on a number of things. Probably the biggest one, and certainly the most relevant one, is looking at quality, cost, and value among U.S. hospitals. So I think that's why I'm here today. And obviously, we're talking about integrated care. The ACA has sought in any number of ways to try and fulfill on the promise, deliver on the promise of integrated care, higher quality, lower costs, and all of that. But that has raised some concerns about, are there any unintended consequences? And so people have a little bit of a complicated view sometimes about these things. I'm going to be a little bit of a devil's advocate today on this topic. Integration means different things to different people, but some people, and including the antitrust authorities, draw a distinction between clinical and financial integration. And the view, obviously, from their point of view, is that clinical integration is good, but financial is, at a minimum, worrisome. And, the sort of conflicted mindset that some people have about this sort of thing is really, I think, nicely embodied by this quote that policymakers both revere and revile these health systems. That's sort of the challenge. So moving on, I do think it's important to note that antitrust authorities, despite their concerns about consolidation, they nevertheless do recognize the potential benefits of integrated care. So that snapshot in the upper left is the Federal Register notice about a safe harbor for ACOs. So saying that organizations that don't have too large a market share and where the provider relationships with the ACO are not exclusive, there's a safe harbor and the antitrust folks are not going to give them a hard time. The one on the bottom right is guidance that was issued by the FTC after the ACA passed to a physician hospital organization in Norman, Oklahoma, at their request, as to whether that kind of organization would raise antitrust concerns, and the FTC said no, you're fine. And really key to our thinking is again this question of exclusivity in relationships. So the authorities do recognize the potential benefits, and as Ann noted, we've been working with CHA and very much appreciate the support. And the thing that I love about research is you're always learning something new. So one of the things that I kind of puzzled over was, I would think that system participation by hospitals might be really strongly related to market concentration and then the things that people worry about. And what we found, in fact, was that the relationship really isn't that strong in general. You can find cases where system participation looks like a consolidated market. There's an example on your left. You can find examples where that isn't the case. So there's 3 hospitals in that system on the right, but across counties throughout the metropolitan areas throughout the Western United States. So really, the relationship was surprisingly weak. I did not expect to find that at all. And here is a key exhibit that came out of the collaboration we've done with CHA. And so the way to read this is a little bit of a busy graph, so I'll try and make it clear. The blue states are states in which per capita hospital spending is below average, and the red states are above average. And then the darkness of the color is, so we're above and below. And then the darkness of the color, whether it's red or blue, is indicating the extent to which the hospitals in that state are participating in systems. Okay, so you can see there's California, blue, so below average on hospital costs, which is noteworthy given the high cost of living. We know there's costly regulations, dignity and discharge, seismic retrofit. You know all this better than I do. I'm not suggesting any of that isn't worth it. I'm not taking a stand on that, but clearly this isn't Texas, so in terms of regulatory environment. So, it is notable. But the thing here that I want to try and drive across is that the darker states, the states in which, whether it's red or blue, the darker states, the states in which there's a high degree of system participation among hospitals, also tend to be lower hospital cost states, right? So that's suggestive that system participation may help contain costs. And the way to see this most clearly is the dark blues in this map are more numerous than the dark reds. Okay, or excuse me, the light reds. Now, I want to bring to your attention a recent study that I think you may find interesting. So this is a guy named Matt Schmidt. He's at UCLA, and he finds cost efficiencies. But here's the thing: only for cross-market mergers. Excuse me. So this is recent evidence, and I think it's very important for a couple reasons. So one reason is there isn't a lot of evidence in support of this view, even though there are reasons to believe it might be true. So you can see that's the study on the top left. The study on the top right is, commentary on the top right, bottom right is from Lee Moore Daphne, who's an economist who's done much of the work, the best work on the price effects of mergers, and also served as the deputy director for healthcare and antitrust at the FTC. And you can see what she said. The harsh reality is that it's difficult to find well-documented examples of mergers that have generated measurably better outcomes or lower overall costs. Now, I'm very careful here to put the dates, right? Because her commentary was back in 2015, and now we see this emerging evidence, and that's very interesting. I wonder where it's going to head. So that was one point that we finally have some evidence that maybe some of these efficiencies are being realized. The other thing that's interesting, I think, about this study by Schmidt is why is it that we're seeing the efficiencies in cross-market mergers, right? If it's about group purchasing power, you would see it without regard to geography. If it's about translating best practices, presumably it's easier to translate best practices to across organization facilities that are co-located with one another, right? But we see just the opposite. And so, I think the study is very good, but it doesn't really get into the mechanisms. And I think there's a story that needs to be unpacked here. Maybe there are sort of system efficiencies in general, but what happens is there are within market, when the merger's within market, it could be the case that you have sufficient scale to make to justify costly investments in new technologies and that kind of thing. And so that would generate this kind of interesting pattern, but it remains to be explained. I'd love to hear as a matter of fact, what you all might think about that. Oh, so also as part of this work, in collaboration with CHA, we look for quality effects of provider integration. So there's obviously been a lot of work on price effects. The evidence on quality effects is less developed, and so that's why we thought it would be nice to do that. So we looked at it in a number of dimensions, so system participation, which I already talked about, but also relationships between hospitals and physicians. And we looked at mortality, readmissions, and satisfaction. And honestly, we didn't find a real strong pattern emerging. And so, thinking about that, I want to just take a minute to share what I perceive to be a challenge for all of you, and also I hope to maybe provoke you into giving me some very good research ideas. So, when we think about evidence, the policy, the sort of gold standard for evidence, as we all know, is a randomized controlled trial. And that's been, the standard or the norm in biomedical sciences. Increasingly in social sciences, that's been embraced. So this year, the Nobel Prize in economics went to a number of people who are doing randomized controlled trials of interventions in developing countries, okay? Sometimes a randomized controlled trial is not on the table, but then people will look to what's the next best standard of evidence? Well, so it's a natural experiment, right? So in this context of health, you could think about, okay, what is the effect of air pollution on health? We know it's not a good thing, but how bad is it, right? And the problem is that, say, poorer people tend to live in more polluted areas, so there's this confounding going on. So, an example of how to deal with this with a natural experiment is to recognize, this is a Berkeley economist who did this, is to recognize that weather patterns on the East Coast generate airport delays on the West Coast. And so airport delays on the West Coast lead planes to idle on the runway longer. And so the communities that are located near those airports will have just randomly higher levels of air pollution on certain days. And then you ask, okay, do they end up more in the hospital? All right, so that's a natural experiment. What is the randomized controlled trial? What is the natural experiment for integrated care? It's it's kind of hard to think about or to do. Do I think that integration could help to generate cost efficiencies? Personally, I do. And the study in the map I showed you is suggestive of that, but it is not the same degree of evidence that some people are looking for. Policymakers, as much as it may be hard to believe sometimes, policymakers, some of them at least, really do want to base their decisions on good evidence. And different people will have different standards of proof, but that, what I showed you is suggestive and worth further exploration, but it's not there yet. And that's, I think, the challenge that is present in this context, because it's really important to get the right answer, but it's really hard to get the right answer for some of these very complex contexts. And I would note, there are two kinds of mistakes that can be made. So a policymaker, right? So I guess what I'm suggesting is, we have to think pragmatically. People are going to draw the line in different ways, but we have to think pragmatically. So a policymaker can support a policy that is not worthwhile because the evidence just happens to be there. That will sometimes happen by chance. Or they may not support a policy that is worthwhile because the evidence just is hard to come by, right? I think a really good recent example of this is last month, the Nutritional Recommendation Consortium came out and said, okay, well, go ahead and keep doing what you're doing in terms of red meat and processed meat consumption. And so today I had a bunch of bacon this morning. And you probably know this was met with fierce backlash by a lot of public health groups, because they said you're holding, it's really hard to do RCTs, randomized controlled trials, in the context of nutritional science, right? And it's unreasonable to hold, we should use the best evidence we have, even if it's not perfect. Okay, so I'm just trying to highlight what I see as, what's going on here, I think. The other point I want to make about this is that to measure integration, it's really challenging. This is not, one animal. There's all different kinds of dimensions and forms. It's very complicated. And so that I see as a real challenge, and that could help to explain why it's hard to find things. We may be missing something as researchers here, and I really would love to hear from you on the panel, in the audience. What is it that we can do to make progress and provide pragmatic evidence that people who are willing to be pragmatic will use and rely on? So my last slide, I'm just going to share with you some brand new work where we look at productivity growth in treating traditional Medicare beneficiaries admitted for a number of causes. So we're looking at episodes of care here, right? And so obviously the question of care coordination and integration comes up. And so 8 different kinds of episodes, and we follow people 90 days after the initial hospital discharge. And the bad news is you can see for heart failure, we see negative productivity growth. Okay, so that's not great. But for 5 of the 8 conditions, we see positive and statistically significant productivity growth, and in some cases quite robust. So for example, on the right, COPD, we see annualized growth in productivity of 1.2%. That's very robust. And so, this is, I think, very striking. And one of the things I want to do but haven't done because it's just brand new is to ask, well, maybe, again, because these are episodes of care, maybe where we see hospitals collaborating with physicians, where we see hospitals participating in systems, maybe that might help to explain some of this favorable performance that we seem to be seeing. So that's kind of what I had to say, and I'll stop there. Thanks so much.
No, that's awesome. Thank you, John. And I know, again, I said questions at the end, but there were just like 4 that I had in there. I'm just going to ask one right now. I'm going to put you on the spot, but you're living wild today because you ate bacon.
Right.
So you said, in your opinion, integration could help to reduce costs.
Yeah.
Are you saying clinical integration, financial integration, or both?
Well, I'm not sure you can have one without the other, right? There's some like frontier of what are the combinations that are even available as a practical matter. So I think that's what policymakers are struggling with. I don't think you can entirely divorce them, but how far you can get, I don't know. That's a good question.
Great, thanks. Well, let's move on to our final speaker today. Let me tell you a little bit about Dr. Barry Arbuckle. If you all aren't aware of Barry, he is the president and CEO of Memorial Care. He's also Memorial Care is an integrated health system in Southern California. As I said before, they have over 200 points of entry, 200 sites for care for the communities that they serve. Barry and his organization are really transformational leaders in developing innovative strategic partnerships to form meaningful and successful care integration. And that has resulted in less hospital inpatient volume, which is kind of an interesting, approach to take. But it's the direction we're going. So Barry is also a PhD graduate from, since we're talking colleges here, from the University of North Carolina at Chapel Hill, and that's one of the reasons I like him. Go Tar Heels. Barry, turning it over to you.
Thank you. I must say I was, when Ann called me about serving on this panel, I was initially a little hesitant because, for two reasons, really. One, she mentioned that the other two panelists were Dr. Rideout and Dr. Romley, so I felt like the guy going to a sword fight carrying a toothpick, knowing the kind of data that they have access to. And the second reason really was it felt to me a little bit like preaching to the choir, because I'm familiar with this market, and I know that a number of the organizations in this market, and indeed in this room, are integrated delivery systems pursuing value-based care with some vigor. But I think, as we all realize, we are in the distinct minority that, frankly, most health systems might talk about value, but then they will blissfully live in the fee-for-service world because it's predictable and you make more money. And so the reason why I occasionally go on rants, which I can't promise I won't today, is because it concerns me that if we don't move this health system, speaking broadly, in the right direction, the direction that Dr. Rideout is talking about, Dr. Romley is talking about, it'll be done to us. We'll get more wholly ill-informed ideas like Medicare for All, which is just really, in my opinion, beyond idiocy. So with that, let me move on.
Beyond idiocy.
I'll make the two slides just because we don't have assets in this market, and I'm going to talk about some of the results of our integrated system delivering value-based care in risk-based type contracts. And so just a couple, just to orient you to Memorial Care, and maybe not different than a number of the systems in this room. We have the hospital division. We do have a health plan. It is nothing like, for example, the Sharp Health Plan or the big commercial plans. This was a little Medicaid plan, Medi-Cal plan, because we have a very large children's hospital. And I frankly wanted to be higher up the food chain as Medi-Cal went to manage Medi-Cal. Our physician division is frankly where the lion's share of the expansion and the action is in the health system, not to suggest the acute care hospitals are not critically important. But we've taken a path of expanding the health system fairly dramatically, as Ann alluded to, into not only our physicians' offices and relationships, but also in the ambulatory sector. So the purple is where a lot of activity is happening, and an immense amount of care is being delivered at a very good cost point, the right side of care, if you will. I don't have urgent care centers on here. I don't know why. We have 15 of those. With imaging centers, the ambulatory surgery centers, and the dialysis centers, we took an approach, even though we could have done it ourselves because we have provided those services for decades. We took an approach that I like to say is partnering with someone that does it for a living, and that's all they do. And so with the imaging centers, we partner with RadNet, which is the nation's largest ambulatory imaging provider. On ambulatory surgery, we partner with SCA, and in dialysis, both clinic-based and home-based, which I'm fairly enthusiastic about, the home-based dialysis, we partner with Fresenius. We do have, there's a TBA on there only because the attorneys won't let me say anything about it. We do have another clinical area we'll be moving into in the next 90 days. We'll be adding another 15 to 18 locations. And it's another ambulatory service that we refer out to a potpourri of people, and we decided we want it done in one way, the right way, fully integrated. And so it's going to be another joint venture with someone that does that business for a living. We have an innovation fund, like I know some in this room might. We've had this one for 18 years. We invest in startup companies in healthcare that we believe can produce value, either improve quality or reduce cost or both. The typical reason you have a private equity investment fund is for the liquidation event that happens in 4 or 5 or 6 years, where you invest $3 million and get back 15. We've had some of those, but that is way down on our list in terms of importance. I sound like I work for a nonprofit health system. Ours is really how can we help these companies that seem to have a really good idea develop their product and get it to market. And in many cases, it's helping these geniuses that invent these or come up with these ideas or services learn how to market to health systems, because many times they have no idea. And so that's been very good for us, and there may be an opportunity to talk about a couple of the products that are producing value. And then on the right-hand side, our shared services, it is really why we call ourselves a system. This is where at one location, everything for the entire health system is done the exact same way by the same people using lean processes, with the entire reason for their existence to drive down the cost at delivery sites. I often say that our hospital in Long Beach, which has been around for 112 years and is rather sizable, doesn't really need the shared services, or corporate as we don't like to call it, to do their central business office. They were quite good on their own. And so if we can't do it better and cheaper, then we should just give it back. And that's the philosophy within our system office. This is how we look currently in terms of our geography. We're only in South LA County, Orange County. Somewhat unusual as health systems go, at least nationwide, with technically 5 hospitals, but more than 200 delivery sites of care. Most of the ambulatory sites are not under the hospital license by design, and I'll touch upon that in just a few moments. I share this quote from Fitch Rating Service, which nonprofits, it's not unimportant what the rating agencies have to say about you, particularly in terms of the cost of your debt. But I share this more as an encouragement that for those that pursue value in the current reimbursement system, for a lot of your revenue, it will not be accretive to you. And one of my concerns was these analysts at the rating agencies with their green eye shades on might look at our net income, which is woefully below a AA rating, and say, you're not worthy. We're going to give you a downgrade. But we've been explaining to them exactly what we're doing and why we're doing it. And they appear, as you can see in that last line, to actually believe in value-based care. Now, in all candor, it might also be that I have a robust balance sheet with 400 days cash on hand that gives them some comfort. But they at least express that they understand where value is going and that the reimbursement system is continuing to catch up with it. For those, and this may be overly simplistic for this audience, and I apologize, at least as I look at the value-based plans and differentiate them from the typical health plan relationship that we have historically had, I kind of divide them up into these 5 areas or these 5 rows. The traditional way we have worked with health plans over the years is in a very broad network. It gives very little coordination. Whereas in value-based plans, it's typically a narrower network, which used to be a 4-letter word, but now I believe is getting some recognition that it deserves, of high-performing assets, typically taking risk for their performance. In the traditional plan, from a data perspective, the providers, frankly, are flying blind. We could not get the data that we need to make decisions from those that have the data, that are paying us or others. In the value-based plans, we get an immense amount of data. Now you have to have an infrastructure to deal with that. In our highest risk plans, which are those that we have directly with employers, we get all data. And we get it also very rapidly, which makes an immense difference in the ability to actually bend the cost curve and improve quality. Traditional plans, it's more of the pay for volume. On the value-based plans, it's more pay for value. Et cetera. I won't belabor this, but there's a distinct difference between the two as I look at the traditional plans versus the value-based plans. This is just a quick snapshot of the last 8 or 9 years of some of the moves that Memorial Care has made with the intentional focus to drive toward value. Again, in not in all cases is it beneficial to our health system. I mean, I'll just give you a very tangible example. A year and a half ago, I found myself in a standoff with one of the big health plans. I won't name them because they're probably a sponsor here, but they're big. And we were basically battling over a 1% difference in my reimbursement for my health system. This health system, we have about $250 million of business a year with this particular health plan, and so that's what, $2.5 million. Yet I could demonstrate to them that voluntarily, without policy, without requirement, because I was driving hospital outpatient business out into community-based centers at 1/3 the price, I had saved that health plan $28 million a year. And we went to termination over a $2.5 million increase in my rates. So that's my point. And sometimes the decisions you make to do the right thing to move toward value might not be recognized until the system begins to catch up. And I believe it is. I actually very firmly believe that it is. This is our, just in terms of all the backdrop, our risk experience kind of by risk product. We just stayed completely away from the no risk or quality upside contracts, but we have an array. This is an older chart now because we've added 2 more new ones just in the last 90 days that are upside downside risk-based ACOs with two health plans in California. But you can see the array of things, and I'll touch upon some of the performance under these in just a moment. The parens around the next gen ACO, the second column over, is simply reflective that we exited that program for very specific reasons, not unlike 2 other very well-known and respected value-based providers in Southern California, the only 3 that were participating at the time, which should have been a statement to Washington, D.C., but I think it was lost somewhere on the way. So I'll just pause on this for a moment. We've pursued the value-based plans, the ACOs, direct-to-employer type relationships very aggressively. It's how we're, to some degree, differentiating ourselves in our market, and it also allows us to pick up market share, which also allows us to perform well because the market share I'm picking up from my competitors is in the benchmark year to which we're being measured against, and I can outperform them because they're still funneling all their ambulatory business into their hospital centers and charging, higher rates, and I'm not. And that allows me in the early years to bend the cost curve and get that money back from whomever, the health plan or the employer. But we are one of the founding members of Vivity, which is kind of an odd duck, 7 somewhat overlapping, occasionally competing health systems that came together in a joint venture with one health plan, taking risk across the board. And Vivity has done reasonably well. I would say it has a challenge in that it continues to find itself challenged with meeting the right price point. And in part, a couple of the members in Vivity are fairly high-cost organizations and have a difficult time getting the price point at the right place. But it has, I think it has 45 or 48,000 members right now, so it's moving along reasonably well. We have every stripe and style of ACO that exists. We have ACOs in the back of PPOs. We have ACOs in the back of HMOs. We have attributed model ACOs. We have the product or designated model ACOs. And we also now have the direct-to-employer relationship. So we're experimenting with all of them. I'll expand upon the one that is really demonstrating the greatest value of what an integrated delivery system can do in a narrow network to both cost and quality on an upcoming slide, but it is what's called the Memorial Care Health Alliance, which is our direct to employer contract with Boeing. I mentioned the Medicare Next Gen ACO, which I must say when it came out, I applauded the federal government, which I don't often do, because I thought it was rather innovative. We did look at the Pioneer ACO when it came out and went all the way down the path to the 11th hour, and we opted out before it started, in large part because we were beginning to get into a number of commercial ACOs. And when we looked at the data of what was then, I can't recall in the first year of the Pioneer, there were 20 or so members nationwide, and we were in the lowest decile of cost per Medicare recipient per year. before the program started, yet had all the requirements of everyone else. And it's like, do we really want to put that much effort into this when the benefit is going to be rather minimal? And do we really want to deal with the government on a program that they've never done before? Probably a wise move that we bowed out. But when NextGen came along, I think it made really great advances, and I applaud the federal government for some of the efforts, and particularly under the current leader of HHS, pushing us more toward value. But you can see, we dropped out because you can see the numbers there on that second, or one of the last lines on the chart. The National Opinion Research Center, University of Chicago, through their report, suggested we saved, in 2016, the federal government $12.6 million. We were one of the best performers in the nation on almost every quality metric, yet I owed the federal government $5.8 million that year. And it's like, what the hell? I mean, why? And it was because of some of their quirky rules, which I shared with them, and they acknowledged they were quirky, they were illogical, they were senseless. They're not going to change them, but they're quirky, illogical, and senseless. And so we said, we're going to drop out, and rumor has it a few others in Southern California, which, by the way, Washington, D.C. looks at Southern California and regularly says, if the rest of the United States health system could perform like Southern California, we'd be in far better shape. And so knowing that, I went to them, because I happen to know the second person down at HHS, and said, do you really want 3 providers, one of whom is in this room, to drop out of the NextGen ACO, your hallmark program, in Southern California? And they couldn't move quickly enough, and I think we all dropped out in a 2-week period, which is an unfortunate statement. So enough on that soapbox. Here's just a few stats. Isn't that lovely? I made sure it wasn't a max 8. Actually, the first version of the slide had a max 8, and it just didn't feel good. That's not good. There's a number of them now, but we were the first direct-to-employer, which doesn't mean anything other than you get on the DMHC's radar really fast, because they want to figure out how they regulate you. And they're obviously attempting that now. We, as a health system, we're not as big as a lot of other health systems in terms of the geography that we cover. And so with most employers, if we want to work directly with them, we don't cover their geography. And so it really relies upon us partnering with other like-minded people. And that's the case with the Boeing relationship. They have a fairly high concentration of employees and retirees up in the Palos Verdes area around Torrance and the South Bay. We only have a few clinical sites up there, but we reached out to Torrance Memorial. We've known them for years. They're very value-focused, and they are a risk-bearing partner for their fair share of the Boeing business. But we also had to reach out to the Monarch IPA because we needed a few primary care provider sites up in Northeast Orange County, where I don't yet have any. And because of our long-time relationship with Monarch, they're willing to allow those doctors to participate, fortuitously, without saying, if you want those doctors, take us all, because we would like to play in this game too. They didn't do that, which was good. But you can see the stats there, and they are somewhat the antithesis of what health systems over the years have focused on, certainly for most of my career. When we'd wake up in the morning and if the census was high, we were giddy. And particularly when you looked more closely, and if the NICU was high, it was going to be a good week. That's sad, but that's the way we looked at it. In this relationship, it makes sense for us to reduce inpatient admissions, and we did in the first year by 22%, reduced ED visits by 47%. And the biggest concern we had, I must say, we had very robust discussions among our management team as we were contemplating going through this RFP, getting into this Boeing contract, and learned that we had responsibility for the total cost of care, including pharmacy. You want to see me get on a soapbox, it's on pharmacy. But it feels so out of control, so unbridled in its cost growth, and I think a lot of it is wholly inappropriate. But we were going to have risk for that. The first year we reduced the Boeing's spend for the members that were in our ACO by 22.5%. And that was on top of the fact that they had a PBM for 5 years, which led me to wonder, what in the hell is the PBM doing? If in the first year we've never managed pharmacy in our lives, and we could reduce their spend by 22.5%. In the second year, it was another 8%. So there's opportunity there if you put the systems in place. Boeing did come to us in the second year of a 5-year contract, which, just as a side note, in these types of high-risk relationships, I'm a big fan of long-term contracts because a lot of the decisions you'll make, a lot of the things you'll do will not pay off in year 1 or year 2 and maybe not year 3. But in a 5-year contract, you can begin to get a return on investment. And Boeing came to us and moved the contract to become an 8-year contract, which it is today. Behavioral health has been really a kind of a wake-up call, I think, for all of us that we're not doing right by our community, by our members, by the patients we work with, because we haven't done a good job in behavioral health by and large. In part, it's some legislation that I think was well-intentioned but had the wrong effect in the state of California. So we decided, part of it's because my background's in psychology, so I felt that I had to. We decided we needed to begin incorporating behavioral health at the point of care in our primary care clinics. And so we decided to test it to see what the effect would be. We already had data that suggested it could be quite powerful. We've done Medicare Advantage since Medicare Advantage was started and have been in it ever since. And so we have a lot of data. And when I saw data that showed 2 very large populations of seniors with the same clinical diagnosis, but one of them had depression or anxiety, the other one did not. And our medical costs were 400% higher for that group that had depression or anxiety. It was like, there's something to this. And if you're in risk-based contracts, not to sound crass, but that's gold. Because any money you spend embedding, as we did, LCSWs overseen by one psychiatrist and using telepsychiatry into our primary care clinic so they can immediately hand off that care, not say, let me get you an appointment 2 weeks later, because what do depressed people do? They don't come 90% of the time, but doing it right there in the clinic. And we started financially sensibly with our risk business because that's where it makes sense. But we decided, you know what, it's not right to have 2 levels of care, 2 tiers of care. So we've now expanded it to the entire population and are doing it incrementally over the course of time. This is one that I know is not, doesn't win me much applause when I speak at hospital meetings. We did make I'm not a big fan of site neutral payment in spite of what some people might think. I think that's a blunt instrument by the federal government. It was simple and I don't think that wise. However, I also don't believe that we should be sending as many patients just because we can into our hospital outpatient departments. When employers see this data, and I must say I share it with them on a regular basis, they're flabbergasted and then they're mad. And they're first mad at health plans because they look to the health plans to protect them because they don't know that XYZ surgery center, the same procedure, you can see on the screen, these are my data. These are not made-up data, and these are not charges, for God's sakes. This is real cost. Knee surgery, that's an arthroscopic knee surgery, in my hospital outpatient surgery center, $9,000. The exact same procedure by the same doctor on the same patient in my ASC, a third as much. And I've got example after example after example. Now, do HOPDs deserve higher reimbursement? Just stay on that rant for a moment. Yes, they do. The question that we need to ask ourselves is, and the reason why they do is because they tend to get the more complex patients that need to have proximity to hospital services, and that deserves a higher reimbursement. So the question really is not, should we pay HOPDs more or not? It really is, does the patient need to be there? And I didn't know the answer. I'm not a clinician, so I had our chief medical officer look at 2 very large data sets of people that went to HOPDs for both surgery and imaging, which I'll show in a moment. And tell me what, on a clinical basis, what percentage of them actually needed to be in an HOPD setting. In one sample, it was 22%. So 78% did not need to be there and were paying the higher price. In the other data set, it was 24%. Now that may be different at every health system, to be sure. I mean, so this is an area that, and this has allowed us to perform very well in our ACOs because, again, when we contract with an ACO, we become a narrower network. We're picking up market share from our competitors. They're very likely using extensively HOPDs. We tend to drive it into community-based market price settings and allows me to, in the first year, just on that one indicator alone, bend the cost curve and perform better under that ACO. Here's the same concept with imaging, whatever brain MRI is. That's the price delta. It's not insignificant. Now, it's important to note this, and I'll just go back, because one of the concerns that my team had, and rightfully so, is, Barry, this is lovely. You get on your rant and say this is what we're going to do, but it's going to seriously impact our hospital performance. And that's a fair point, because the HOPDs are a little cash cow in many organizations. The chart on the left shows the percentage over the 6 years of our inpatient surgery, in this case, our HOPD in orange surgery, and then the expansion of our community-based. You can see we haven't cannibalized ourselves. We haven't eaten ourselves. We've actually picked up more market share, particularly in the ASCs, because our model is partner with somebody that does it for a living and then bring on physicians and let them maximally invest in the ASC. They're moving their business there, and they're moving it to my HOPD as well for the patients where it deserves to be, and my inpatient hospital. So we're picking up market share as we've gone. So it hasn't impacted us that significantly. And then last two slides, just as we're on this discussion about integrated care and improving value, cost, and quality. And it's the CIN. And I only mention this because I am just flabbergasted, and even though we're only a little over a year into our CIN, with the impact it's having. The idea for moving down the path toward a CIN, and when I say CIN, I like to differentiate this. A lot of people say they have a clinically integrated network, and they should just use lowercase letters because that has as much meaning as an affiliation. It doesn't mean much. It can mean anything. When I say CIN or clinically integrated network, I mean the one approved by the Office of the Inspector General, the one that allows you to share savings with doctors without going to jail, or without my CFO going to jail, because that's who it would be. That's the benefit of being the CEO. But the idea for moving down this path with some vigor was our participation in BPCI, the Bundle Payment Collaborative, which, as you know, was for traditional Medicare patients. And we worked with our orthopedic surgeons and with our cardiovascular surgeons to standardize what they use, to use the OR in the same way, to really drive down costs, fundamentally changing what they've done so as hassling them and saving somebody else money. And why should they do that? Well, if you can share the savings with them, that's why they might want to do that. But the frustration was this. Once I got the orthopedic surgeon, who might have grown up in a fee-for-service world, to really begin to play ball, and that surgeon had two cases back-to-back. Let's say it was a hip replacement procedure. One of the patients was 65, one was 62. They do the same thing on both. I can share savings on one of them because they're a Medicare patient or BPCI. The other one, I go to jail because I can't by law, by Stark, because it's so horrifically outdated. The CIN allows you to sidestep Stark. And so we're right now, in the first year, have already demonstrated over $10 million of savings inside the hospital on just 3 programs. And really the sky's the limit. You can just continue to add them and now expand it to the ambulatory setting. So it has been enormously beneficial, but it does really integrate and align the incentives of the hospital and the physicians toward that goal. I don't know why this thing does this. We look at our CIN as just being another puzzle piece in the way we work with and relate to physicians. Most of the docs that we work with on our CIN are not in our owned medical group. They're not employed by us. They're not in our aligned IPA necessarily. So they're the community doctors. So it gives them a way to participate with the health system in driving value. So with that, I will conclude.
Can I have the clicker?
You certainly may.
Because I want to put back up a slide.
Uh-oh.
This one. Just congratulations to you. I look at that and I just get exhausted.
So do my attorneys.
Yeah, I mean, that didn't happen by accident. I mean, that's a lot of work, a lot of hours, a lot of resources. Quick question, because I know others have questions for you. And you talked about the need for long-term contracts so that you can recognize that ROI. When I look at this and I look at all the resources you have to invest into making any one of those little dots happen, what is the general ROI? 5 years, like you said?
You know, it depends what it is. The behavioral health integration, the ROI is within a year, which I think is a message to us all. It is a big opportunity. Now, some I know are doing it well and have been for years, but that is a grand opportunity. Some of the others really depends upon how open the data is that you get so you can actually affect change. And that's been one of the greatest frustrations is getting, to a large degree, the health plans to provide all the data that we need to begin making the decisions. I mean, I'll just give one, it's a memorable example with Boeing. We did something we had never done before in our health system. We've had pharmacists, like all of you have, in our health system for a century. When we began getting into these risk-based contracts and developing our ACO division, we hired 15 pharmacists. None of them prescribed medicine. They're all analysts. They all scrutinize all this data we're getting on drug utilization and then educate our physicians and work with the PBM or the employer to begin to modify their drug formularies. But the stuff they found was astounding. Again, this is on a population that already had a PBM. One of the physicians, the practice was an opioid dispensary. The number they were prescribing should have come up on any flag, and it was not noticed by the PBM, which in and of itself was shocking. Another one was a patient who was consuming $250,000 a year on one drug. That happens. But when you see that, you want to dive into it and understand, is it the right drug for the right diagnosis? And it happened to be a drug, and I'm not a clinician, so I'm out of my league here, but it was a particular medication that was exclusively for castration-resistant prostate cancer. And I thought, okay, all right. She had been taking it for 3 years. My first thought, I'm in California, it was like maybe she was a he at an earlier point in her life. No, she had a baby. So what in the world? And then I thought maybe I've heard that sometimes breast cancer or prostate cancer, the drugs, there's an overlap. Not true either. This was a case where a doctor just thought it might help this particular patient for whatever ailment it was, and I didn't get any more detail than that. And so that, I mean, it's amazing what you can find when you have the data, and that's really one of the biggest lessons learned from us.
Thank you. Quick hand for the panelists.
That's good.
And Demetrius, I think we have a few minutes for some questions.
Thank you all so much. The question is mostly for Dr. Rideout about how you measure value and what value looks like. When you're talking about value-based contracts, obviously there's the upside and downside risk, the financial side of it, but of course that doesn't mean that HEDIS and these other metrics or the measure sets you've worked on take a decreased maybe they take a decreased role, but they don't go away. They're still a component of measuring value. But what's the balance between those two things? And the reason I ask is, of course, with Governor Newsom's focus on pediatric health, there's been a vast expansion in the number of pediatric HEDIS metrics, which I know makes the folks on the health plan side here nervous, and it makes me nervous as a federally qualified health center person who's going to have to measure all these metrics. And how do you grapple with the balance between those two things and make sure that we're really measuring value effectively and not increasing administrative costs to measure things rather than deliver high value care?
Well, there's a lot of embedded in that question, but here's what I'd say, and it may not be all that satisfying. We don't have to measure everything to understand where the opportunities for improvement are. And so as long as we measure enough of the right things in the same way, we can draw some conclusions, I think, comfortably from that from a benchmarking point of view, not to do performance improvement on a daily or weekly basis, but to say this is where we should start to make an improvement. And one of my mentors way back said, let's just make sure a random choice is a safe choice. So my feeling, been in the industry this long, we're still trying to find where a random choice is a safe choice. And the other thing I'd say, a lot of our data suggests if you do one thing well that requires integration, you'll do most things well. So I didn't show a slide, but what we see in diabetes care, the groups that do well in diabetes care are the groups that do really well on asthma care. They're the groups that do really well on cardiovascular care. They're the groups that do really well on cancer care. So I think it's gotten a bit, apologies to the academics, and I do teach too, this quest, like we want to measure everything because anything anybody can think of needs to be a randomized controlled trial proven, I think is kind of taken us in the wrong direction. And one of our jobs at IHA is to try to corral the cats, and it's getting worse, not better. I mean, having people say this core set is a proxy for performance that allows us to then say, these are the people doing well, these are the people that need to do better, and let's just start there. I mean, we're all getting lost in the cacophony of measures, and everything's got to be measured. So that's my soapbox a little bit, because I don't think it has to be that complex, to be honest.
Let's go ahead and give this panel a round of applause.